Empathy among college-age students has been declining over time, and the speed of that decline is actually accelerating. 80% of our youth believe that their parents value the kids' achievements and their accolades more than they value the kids' kindness for others. We have a compassion crisis indeed.
Dr. Stephen Trzeciak. He's a physician scientist and researcher specializing in the science of compassion.
47% of Americans believe not only that our healthcare system isn't compassionate, but that our healthcare providers are not compassionate either. It begs a question, so what? I mean, does compassion really matter?
He's analyzed data from over 1,000 scientific studies, and what he uncovered could change the face of healthcare forever.
Knowing the patient as a person was independently associated with a 20% higher odds of having no detectable virus in the blood. She was dying, and there was nothing that could be done to save her. She asked me a question that I had never been asked before.
This is the Curiosity Blueprint, brought to you by Flying House Media.
Research from Johns Hopkins has found that 74% of interactions between the ICU care team and patients and families in the ICU is devoid of compassion. 1/3 of end-of-life conversations has 0 expressions of compassion.
And today, Dr. Trzeciak joins us to share what he's found.
So what I was taught in med school is don't care too much, because too much caring burns you out. And I believed that dogma for 25 years.
Where I want to start with for you is there's a big difference between compassion and empathy. And I think maybe not everybody even understands what compassion really looks like. Can you explain that to me?
Absolutely. And it's vitally important because I like to look at familiar things in unfamiliar ways and examine things that we typically view through a moral or ethical lens or emotional sentimental lens. And I try to view it through the lens of science. And one of the most important things with any scientific discipline is having common nomenclature. So what is compassion in the first place? So most researchers define compassion as an emotional response to another's pain or suffering involving an authentic desire to help. So it's distinctly different from a very closely related word, empathy. That's the sensing, feeling, detecting, and understanding another person's pain, suffering, or struggle. But compassion goes beyond empathy because it involves taking responsive action. So a really easy way to remember it is this: empathy plus action equals compassion. And these aren't just semantics. There are robust neuroscience data behind this distinction in terms. So using a brain imaging modality called functional MRI that can show us what part of the brain is being activated at any given moment in time, when you bear witness to pain and suffering and you have empathy for those people in suffering and struggle, it actually activates the pain center in your brain. And you know this experientially because it is so uncomfortable to watch people suffer. But what the same research modalities show is that when our minds are focused on serving, helping to alleviate a person's suffering or struggle and taking action in some way to help, that it activates a distinctly different part of our brain. It's not a pain center of the brain. It's what neuroscience researchers call a reward center of the brain, associated with positive emotion, positive affect, feelings of affiliation. It's part of the reason, and again, we all know this experientially, but it's part of the reason why it feels good to help people.
I think one thing that I notice is people may say, of course we need more compassion. Of course, that's kind of I think you had said in one of your books, that's the cherry on top. It's a nice extra if you can have it, but is it really necessary? So when we look particularly in healthcare, why is compassion so necessary as an actual act rather than just saying it's something nice to have?
So Dr. Maz, that's my colleague and co-author, Anthony Mazzarelli, we had to be very open to the possibility that compassion didn't really matter. So whenever you test a hypothesis, you must be agnostic to the hypothesis. So our hypothesis was that compassion matters, not just in meaningful ways, but also in measurable ways. And our approach to testing that hypothesis was systematic review. So we went through more than 1,000 scientific abstracts, over 280 original science research papers. And what we found was a very distinct signal in the data that compassion isn't just a nice to have, that it's actually vital to the quality of healthcare and vital to healing. So it makes measurable, not just meaningful, but measurable impacts on the quality of care. So it impacts patients, and it also impacts those who care for patients. Not, again, not in just meaningful ways, but also in ways that can be measured.
And I think that is such a significant part of this. That science is not, compassion, like you said, is not a feeling; it's an action, but it is also a science. There's measurable impact. And in your book, Compassionomics, you mentioned that we have been on a decline. There has been a decline of compassion in healthcare over the last 5-10 years now, to a degree where you say we're in a compassion crisis.
And there's evidence of a compassion crisis in society broadly. So really the question is it just spilling over into healthcare? And so the data support a compassion crisis more broadly. For example, a University of Michigan meta-analysis over 2 decades found that empathy among college-age students has been declining over time, and the speed of that decline is actually accelerating. A Harvard Graduate School of Education study of 10,000 youth, so these were middle school and high school students in the US, found that 80% of our youth believe that their parents value the kids' achievements and their accolades more than they value the kids' kindness for others. And in a striking Pew Research study from just a few years ago, fully 1/3 of Americans endorsed that they don't consider compassion for others to be among their core values that describes them well. But healthcare is supposed to be different. So I've always believed that compassion was a cornerstone of the art of medicine. But what Dr. Maz and I did in our work on Compassionomics and our later work is we tested the hypothesis that compassion is not just in the art of medicine, but there are also evidence-based effects belonging in the science of medicine. So the question is, what is the evidence? And it's in the contemporaneously with the evidence that we actually have a compassion crisis in healthcare as well. So a Harvard Medical School study published in the journal Health Affairs found that 47% of Americans believe not only that our healthcare system isn't compassionate, but that our healthcare providers are not compassionate either. And in my domain, critical care, I'm an intensivist. So I'm a specialist in intensive care medicine. If you become my patient, it's because you need life-sustaining therapies in the ICU. We often meet people on what they consider to be one of the worst days of their life. And research from Johns Hopkins has found that 74% of interactions between the ICU care team and patients and families in the ICU is devoid of compassion. In fact, a University of Washington study has found that fully 1/3 of end-of-life conversations in the ICU, end of life, has zero expressions of compassion between the care team and the patients and families in the ICU, and that's at the end of life. So based on all these data and more, Dr. Maz and I conclude that we have a compassion crisis indeed. The question then, it begs a question, so what? I mean, does compassion really matter? And that was the launching off point for all of the work that we've done with Compassionomics.
Well, I think it also begs the question, why? Especially since we're seeing a decline more recently, not to suggest that compassion was always at the forefront, but we're seeing a decline right now, leading to this crisis. What have you found, if anything, is causing this lack of compassion?
So we believe that there are 3 key components. And when I say we believe, it's actually not what we believe. It's not our opinion. It's not our feeling. It's just what we found in our journey through the scientific evidence. But there are 3 key components. One is realizing that there is, in fact, an evidence base for compassion. So it's not just a nice to have. And when you see the totality of the scientific evidence, that compassion makes measurable differences. You feel differently about your opportunity to treat patients with compassion. You feel like you're wielding something very powerful and very potent and something that's vital. Number 2 is believing that change is in fact possible. And I didn't always believe that. In fact, I thought that people were either wired for compassion or they're not. Like it's something that's in their DNA or they're not. But what the research clearly shows, not just in the healthcare domain, but broadly throughout the psychology literature, is that we can in fact get better at our behaviors in showing compassion to other people. And I am very much a work in progress. So that is good news for me indeed. And the last point is just realizing the time component, because we're very hurried now in healthcare, and we have been for some time now. But what the research shows quite clearly is that we just think treating people with compassion takes a lot of time. In the scientific studies that have actually measured compassionate behaviors that have had measurable impacts on patients, what the research shows, if we're going to be evidence-based about it, it's often less than a minute. In fact, one study from Johns Hopkins University shows that a meaningful compassion connection can be made in just 40 seconds. So I think it's all three of those things together. When you realize that compassion does belong in the domain of evidence-based medicine, there is an evidence base behind it, you realize that change is possible and we can actually work at our compassion and get better at it. And then realizing that it actually doesn't take much time, we just sometimes feel like it does. And once we overcome that cognitive bias, if you will, then that allows us to raise our game, so to speak, in compassion.
Well, the time component alone seems to eliminate one more excuse that there is no reason to not have this. And here's an important part that I want. The one thing I'm very aware of is the world is at times a relatively cynical place. Mm-hmm. I think there, like we mentioned before, it seems to people to be a nice to have. Does it really matter? And you've answered that. But I think what's so important for the audience to understand is these measurable impacts are made in things that each of us deal with in everyday life or loved ones have. So having a compassionate care can lower blood pressure. It can impact the pain levels of IBS, of headaches. Lower back pain seems to be a big one. With 30 million people in America living with diabetes, this can help regulate blood sugar. So are you in your research really telling me that a compassionate physician can have an impact on all of these things in areas of our health?
Short answer, yes, but I want to expand on that a bit. So we have found that there are a total of 24 different mechanisms of action, so to speak, by which compassionate care can improve things in measurable ways. We bucket these 24 things into four different categories. One is physiological effects, one is psychological effects, one is patient self-care, how patients stick to the treatment regimen that's been prescribed for them, and then just on the quality of care. And so I'll start with the practical. So on quality of care, what the research shows, and I'll be summarizing now years of literature, in healthcare environments where there is less caring, patients are less safe. In healthcare environments where there is less caring, patients are less safe. And researchers have found this by studying a key component of the burnout syndrome, which we can talk about as well for effects on those who care for patients. But one of the key components of the burnout syndrome is depersonalization. That's an inability to make a personal connection. And depersonalization and compassion are not opposites, but I would argue that where there is depersonalization, there can be no compassion. Well, researchers have found that not just in hospital-based physicians, but also in surgeons, 8,000 surgeons from the American College of Surgeons, where there is moderate to high levels of depersonalization, there are higher levels of self-reported major medical or surgical errors. And from those data on association, we shouldn't infer causation because those study designs aren't made for that. But if your experience has been like mine, you've perhaps worked with people in the past who seem to not just care, they just don't care very much. And when you look at the meticulousness of their work or the lack thereof, sometimes it's just downright sloppy. But another practical element, and you mentioned diabetes, for example. So one of the key things in diabetes is adherence to treatment regimens. What the data show collectively is that when you care deeply about patients and they know that, they feel that, they are more likely to take their medicine. They are more likely to adhere to a prescribed treatment regimen. In fact, a study from 1,700 patients with HIV, this was conducted at Johns Hopkins University, they measured everything that they knew to be associated with adherence versus non-adherence to antiretroviral therapy to control HIV. Adherence is the key component of that treatment regimen. And what they found after adjusting the analyses for all the potential confounding variables like age and comorbid conditions and socioeconomic status and health literacy, they asked patients one question: does your HIV provider know you as a person? Know you as a person. And what they found after adjusting the analysis for all these different factors, that knowing the patient as a person was independently associated with a 33% higher odds of strict adherence to antiretroviral therapy, but that's not all. It was also independently associated with a 20% higher odds of having no detectable virus in the blood. Now, we don't infer causation from those study designs that show us association, but a causal pathway is not hard to imagine. So a patient feels known as a person. They trust their care team more, and so they stick to the plan. And it's not surprising to me at all that it clears virus from the blood. I think those are powerful data on the power of human connection.
It's unbelievable data, and causation aside, it's an easy path to pave to look at that. So, and I think you answered what my next question was going to be: is that reason for adherence the trust they feel in their healthcare provider? That I trust you as a person, therefore I'm going to listen to instruction.
That's right. When patients don't feel connected to their physician or their providers in general, they often don't have that trust and won't stick to the plan. And so when you feel connected, and this has been shown consistently over dozens of studies, patients are more likely to stick to the plan.
I was dealing with some very kind of intense shoulder pain, the kind of pain that would keep me up at night, that would make me have to be very aware of how I was sitting. I'd have to sit with my arm propped up. And as pain does, it took away from so many different parts of my life, being present with my family, being present at work. I travel a lot. It was really difficult.
Yeah.
So I began seeing doctors to see what the issue was. And the first physician I saw, his first response was, it might be tumors. Let's go scan you and see if there are tumors in your shoulder, which of course I could feel my blood pressure immediately start to rise.
Yeah.
There were no tumors, thankfully, and he sent me on my way. The next doctor I saw very similarly just said, yeah, I don't know what the issue is. Take ibuprofen. I decided to go back for a third doctor, which I was very reluctant to do for obvious reasons, but my wife talked me into it, and I saw a physician, and from the moment he walked in the room, I liked him. He had a nice smile on his face. He reminded me of somebody that I know who's very kind, and he took the time to sit down and not make me feel like I was a burden on his time. And I'd been dealing with this for 6 months. I was at my wit's end at this point.
Yeah.
But he took the time to listen and then said, I think I know what this is. 80% of the time that there's an issue with your shoulder, the problem starts in your neck. And no worries, there's easy physical therapy you do. I think you're going to be okay, but let's go take a look and see if that's what it is. Sure enough, he looked and just saw it was an issue with a vertebrae in my neck, and he gave me some physical therapy to do and told me to check back in with him to let him know how I'm doing. I kid you not, 3 days after that visit, and I will say that I was not good at adherence. I did not jump into my PT yet, but 3 days after that visit, I woke up and I had no pain in my shoulder, and I have not experienced any pain since. I was very aware of my posture, making sure that my neck was good, I was sleeping right, but it was 3 days later, almost as if that peace of mind had kind of helped me get through this and make adjustments. And in reading your books and in preparing for this conversation, I couldn't help but think, is it that kind of care that had some sort of physical impact on my symptoms?
I think so. Listen, the best evidence for that is what you've experienced, right? You experienced some healing in that moment, and no one can change that experience for you. And what I will tell you is that it's also evidence-based, because in the physiological domain, so that's one of our 4 buckets of effects on patients. There is robust research that the touch of a trusted other can actually attenuate a person's experience of pain. Now, I didn't say that compassion eliminates pain, because it doesn't do that. But what research in laboratory experiments and studies of experimentally induced pain, and don't ask me who volunteers for those studies because I have no idea, but both in those domains, or in the laboratory environment, as well as in clinical studies, post-operative pain, as you mentioned earlier, abdominal pain due to irritable bowel syndrome, patients with headache pain attending a migraine headache clinic, patients with low back pain undergoing physical therapy. There are clinical data as well. So the touch of a trusted other, and the key word is trust, the touch of a trusted other can have measurable effects. It's not magic. Like, I don't have any magical thinking. Now, you experience very striking, very quick symptom reduction. And I don't have any magical thinking, but what I can tell you is that the evidence lines up that that compassion from a trusted other can attenuate a person's experience of painful conditions. And that's been shown consistently over the years.
It feels like magic when you read it, but that's why I like having that data to back it up, because it's truly remarkable what the neuroscience shows, how our brain works with our body. And I think you had mentioned something earlier about either that or I read in your book, the power of hope. So being able to speak with a physician who tells you we're going to get through this together, or tells you there are answers, can inspire hope. How does that work on a neuroscience level, where even just the feeling of hope can trigger certain things in your body to maybe make you fight a little longer, or even have your body react to it?
So I think that hope gets a bad rap. You know, there are sayings in business like hope is not a strategy. Well, I think hope is necessary for every strategy, and including, getting through some of the difficult times in your life. I just finished curating the evidence, and it's actually more likely to be the topic of the next book, The Science of Hope. But there are 40 different papers that hope is associated with better outcomes for patients with cardiovascular disease, 30 different papers that show that hope is associated with better outcomes for patients that are diagnosed with cancer. And the list is very long and heterogeneous of conditions that can be affected by a person's hope. And hope is a belief. So rather than an emotion or a feeling, most researchers define hope this way. It is a belief that the future can be better than the present. So the future can be better than today. And I play a role in making it so. Which makes it different from a wish or just optimism, where I believe things will work out, but I just have no idea why. Hope is a bit different. And this goes all the way back to the early 1990s with something called hope theory. It's associated, there are three components. So hope has a goal or an aspiration, either an aversive one or a positive one, meaning like I hope that something doesn't happen, or I hope that something good does happen. And then pathways. Is there a pathway? Can we get there from here? Can we get to where that goal or aspiration is? And then the last part is what most researchers consider to be willpower or agency. It's one's ability to stay on the path, because the path is unlikely to be a straight line. There are going to be obstacles. And to what extent do you have the willpower, the agency to stay on that path even when the going gets hard? So there's a body of evidence that shows that hope matters, again, not just in meaningful ways, but in measurable ways. And again, I have no magical thinking about hope or compassion or any of this, because we examine it through a lens of science, and we've curated all the scientific evidence. So as they say, we brought the receipts.
Well, so here's what I'm curious about. There's so many staggering things that I read in your book that that are almost hard to believe. And one of them, well, I should say two of them, work well together. You mentioned before a study that showed it only took 40 seconds to show the amount of compassion it takes to have an impact. But on the flip side of that, studies show right now that the average time to interruption during a doctor's visit is 11 seconds. Mm-hmm. So what do you believe it is that causes that time to interruption? Again, with all of this data here, what is it that is preventing physicians from believing in this, buying into this, training themselves to be more compassionate?
So you have two striking, contrasting pieces of data there. One showing that the time to first interruption of a patient in the opening minutes of an office visit to go see the doctor, it's just 11 seconds. And then in contrast, it only takes 40 seconds, according to an experimental study among breast cancer survivors, that 40 seconds is all it takes to make a meaningful compassion that can actually lower patients' anxiety level, not just in a meaningful way, but in a measurable, like statistically significant way. And I think what it boils down to is we have some awareness of time. And one of my favorite studies on this studied time affluence. So it was a University of Pennsylvania study where they randomized normal subjects, so this was not in the healthcare domain, to 4 different uses of time. And they measured, the outcome measure was time affluence. So that's the feeling that you have plenty of time, that you're not in a hurry. And they wanted to test uses of time and how those different uses of time impacted your feelings about the time that you have. And so they randomized study subjects to 4 different uses of time. 1 was spending time on yourself. 1 was wasting time. 1 was getting an unexpected windfall of free time. And the last one, the only one that had was associated with a significant rise in one's feeling of time affluence, it was time spent helping other people. So there is something about spending time helping other people that makes you feel differently about the time that you have. Now, some of my colleagues, by the way, bristle at this entire conversation because they say things to me like, there should be no time dimension at all, because you can go through your day with brusque efficiency, whether you're in an outpatient office or in the hospital. You can go through your day with brusque efficiency, letting everybody know how busy you are or how busy you think you are. Or you can go through your day treating people with compassion. And if we held a stopwatch to you, it wouldn't be any different. You just think it is. And so I think we have to rid ourselves of the cognitive bias that meaningful human connection takes an extraordinarily long period of time, because the data don't line up with that.
What it makes me curious about is, what does 40 seconds of compassion sound like, look like, when if you're training an intern or you're working with something, kind of teaching them to take this compassionate approach? What does that 40 seconds of compassion look like? What are the words? And obviously it's not a script. Compassion isn't something you can force, but.
You said it's not a script.
Oh, I was wondering, I was like, I just said something, you're done. So it's not a script, or maybe it is a script. Tell me what it is.
So in the study among breast cancer survivors, so they randomized them to just usual care, a consultation with an oncologist, information only, versus what they called enhanced compassion. And what they found is that the enhanced compassion intervention was associated with a sharp, statistically significant reduction in anxiety among the breast cancer survivors. Now, if you've ever had cancer, or someone close to you has had cancer, you know that anxiety is a really important outcome measure. And so what was this enhanced compassion intervention? So in addition to the information-only consultation, they got just a little bit more. And instead of describing it to you, Jason, I'll just read it to you. So here was the message from the oncologist at the beginning of the consultation. I know this is a tough experience to go through, and I want you to know I am here with you. Some of the things I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We're here together, and we'll go through this together. And then at the end of the consultation, the oncologist again said, I know this is a tough time for you, and I want to emphasize again that we're in this together. I'll be with you each step along the way. And so they measured that intervention, and on average, it was 40 seconds. So if we're going to be evidence-based about it, 40 seconds of compassion can make measurable differences, not just meaningful ones. And I want to also say that it's not just about what you say, but it's about what you don't say oftentimes. So a retired pastor friend of mine who used to make a lot of sick visits in the hospital used to always ask me, what is it with you doctors? Why do you guys always, and I practice critical care. So the sickest of the sick, people on life support and, it's heavy stuff. And so he used to say to me, what is it with you guys? Like, why is it that you always feel the need to fill this silence with words? It's like you think it's an uncomfortable silence. Whereas just being present with people in their hardest times says more than anything that could ever come out of your mouth. So he used to teach me, just show up and shut up. And being present for people says, I can't change your circumstance right now, but you're not going to go through this alone. And, there are no words to capture that, as well as just being present for people.
Well, that's a powerful notion. And we actually, on a previous recording, we had a listening expert on who talked about that very notion of, in particular in America, silence is a very difficult thing to deal with. And there is a compulsion to fill that void. So I do want to point out to those that are watching and listening now that being silent can be a very difficult thing, especially during a painful moment. So I would assume it takes some serious training to understand the impact that the things you don't say would have.
And it's not just what you don't say, but when you do speak, you have to ask the right questions. So I won't go into details of the study, but this actually came from a study from the University of Colorado that was conducted in their emergency department. And what came out of the research is that there's a vital question to ask patients. What worries you the most? What worries you the most? And what they found in this research is what the answer to the question, what worries you the most, 74% of the time didn't match up with what was their chief complaint when they registered in the emergency department. And I have built this into my practice because I try to be as evidence-based as possible. And I've been practicing critical care now for well over 20 years. And I've talked to patients and families, I couldn't even count how many times. And I've started in my practice just adding the question at the end after I thought I was done. Like, we've talked about everything we could possibly talk about. I've given them an answer or an opportunity to ask whatever questions they wanted to ask me and answered them the best that I possibly could. And then I ask one more question. What worries you the most? And Jason, I've been blown away by what comes out of people's mouth. It's things that I never would have guessed were front of mind for them. And sometimes there are things that I can address very easily for them, like, oh, well, I now understand you're concerned about that, but let me assure you that's not what's going on here. And sometimes it's something that I can't do anything about. And what that same retired pastor friend once taught me is, don't be afraid to ask because you want to be a fixer and you think you have to fix everything. That, when just ask. And that just goes along with being present, because you need to resist the temptation to try to be a fixer for everything, and just connect with them and let them know that they're not going to go through it alone, no matter what it is.
And I think one of the number one emotions they feel is a sense of isolation. Mm-hmm. Nobody understands what they're going through. Nobody could possibly understand because people haven't even sometimes heard of the diseases that they're living with. And one thing that I notice is a question like that is freeing for them because somebody finally asked it. Yeah. Somebody is actually taking the time to see me, to hear me, and to actually care what a concern is. And what I find in similar questions to that is that we oftentimes focus so much on the symptoms. What is your symptomatic journey? What is your diagnostic journey, your treatment journey? But what we miss are all the little things that are taken away from our symptoms, the things we can't do anymore. We can't go for walks with family anymore. We can't spend time with friends anymore. And I think once you start opening those questions up to them, and I sit down and I ask somebody, what do you miss most being able to do? That's when you get to the real heart of what a disease is. And instead of focusing on what's on a chart, what's on my list of questions, it's focusing as a human on what would I miss if I was in that situation. And I think that's the empathetic side of things is putting yourself in those shoes and just thinking, what would that be like if I was going through this? And I think I have experienced the same thing, where even asking the question has completely changed my relationship with somebody because it's a question no one's ever asked before. So it's powerful, really powerful.
In the ICU, this was a few months back, I asked the patient was on a ventilator. I couldn't talk to the patient, but I could talk to the family. And I asked the question, well, what worries you the most? And the patient's wife said to me, well, his daughter's getting married in a few months. And he had a very poor prognosis condition, by the way. All he would want to do is make it to that wedding, and that's it. Now, if I don't know that, how will I do a good job taking care of him? It's impossible, because I don't even know what matters the most to him. Does that make sense?
Yes, absolutely. Yeah, and not to just continue to share stories back and forth, but I remember sitting down across from a woman who was living with a disorder called neuromyelitis optica spectrum disorder. Horribly debilitating disease, can take away every aspect of your life, from your vision to your motor skills. There's intense pain. But she was always known as an incredibly tough person, and that is who she wanted to be. She never wanted to show signs of weakness because she's always been the tough one. Mm-hmm. And so in many ways, she has a husband, she has a family, but she would in many ways hide that part of her from them because she needed to be the strong one.
Sure. And
I remember sitting down from her and kind of getting to know her life. And then asking, you're such a strong person. Is there ever a time that you just let yourself cry? Mm-hmm. And there was like this alchemy that happened in the room. There was a chemical change to the room where I saw a woman who was putting on this strong face break down and explain to me that there are times when she just wishes her dad was still alive, to put his arms around her. Yeah. And hug her like he did when she was a little girl. And it makes me emotional actually now as I tell you.
Sure.
But to me, that's exactly like you said. How could I ever know what this person has gone through if I don't know who this person is? And in that moment, she revealed it to me. Mm-hmm. And it's one of those conversations that will, for me, impact what I do for the rest of my life, just because you know that the power of compassion works both ways and can just open a chain in so many ways.
And we've been talking about the healthcare domain, but it's also true just in regular life. I mean, people are pretty good at the poker face, when they're friends or colleagues, the person in front of you in the coffee line in the morning, and they are, you don't know it, but they're actually at the end of their rope. And if we're mindful of that, I think we'll treat everybody a little bit better, because you never know who is going through the worst day of their life.
Yeah, you never know what someone's carrying with them.
Yeah, if it's one thing that, I've been practicing critical care now for like almost 25 years. But just in life and doing life, and being older now, if it's one thing I've learned is you have no idea what kind of pain people carry around.
Yeah. Yeah. When you, as an intensivist, you would know that better than a lot. Well, what I do find important to take a turn from the emotional side, because I think it's so important for our viewers to understand the true impact this can have, not just on an individual patient, but on the American healthcare system in general. Because I think if this can become a revolution, we can completely change, my thought is completely change the American healthcare system. One of the most shocking things I read in Compassionomics was that the American healthcare system spends more money annually than the next 10 top spenders combined. That is, it's almost unfathomable. And you had another stat in there that was people were shocked by the price of $60 billion to clean up after Hurricane Sandy. We spent that last week in healthcare. So I think what that leads me to is this question of how is it that a compassionate care in healthcare can reverse this spending cycle that we're in? What is the impact that a hospital will see, that a physician will see, that our healthcare system will see that makes us believe that this isn't just an emotional decision, this can truly impact our economy?
So first of all, I'll go back to what I said earlier. I don't have any magical thinking about, compassion will instantly make all of the ills of our healthcare system, go away. Of course, that's not true. But what we have seen consistently throughout the literature is that having meaningful relationships between patients and physicians is often associated with less discretionary resource use. Because, for example, when we spend more time actually talking to patients, maybe we don't need all sorts of expensive tests and referrals. But one of the major things that's going on right now, and so this is even since Compassionomics first came out, is that the pandemic accelerated a demographic drought that started many years ago, and the pandemic just accelerated it. And what I mean by demographic drought is people leaving the workforce in healthcare in numbers that are essentially unprecedented, leaving more stress and more work on the people who are left behind. Turnover in the healthcare industry is extraordinarily expensive. So every health system in America, I would be willing to bet, my health system, wherever you get your healthcare, the number one expense is people. It's people, people, and people. And when we have extreme turnover in our workforces, it is incredibly expensive to health systems and just makes our, the chassis, so to speak, of our U.S. healthcare system even more expensive. And what research has shown, and specifically I'm thinking of a study right now that was done by McKinsey and Company, and they were studying the likelihood of people leaving the workforce over the next 24 months. And they studied this across many different domains and industries, but they also studied in healthcare and specifically in nurses. And the proportion of nurses who were considering leaving the workforce was strikingly high, and that's not surprising to anybody, especially following the pandemic. But what they found is the sharpest discriminators, besides things that you would expect like workload and pay and things like that, the sharpest discriminators, because those were not the sharpest discriminators were, number one, a sense of belonging, and number two was having caring and trusting teammates. And so what we focus on, or most of our efforts on in Compassionomics, is compassion for patients. But really, what we need to be focused on in health systems is compassion for each other and taking good care of each other. Because I believe, and everything that I share with you, I could put a citation or a reference behind, except the thing I'm going to say next, which is if we do a good job taking care of each other, how we take care of the patients that we serve will be just fine. And then the flip side of that is when we don't do that, then we have a high churn in the healthcare industry, and it just puts even more pressure on an industry that's already under extreme pressure.
My wife is a nurse. She's now a director, more behind the desk, but patient care is her, being bedside is, I think, her life's purpose. It's what brought her the most. And I know she would come home in the middle of the pandemic and still to this day talk about that burnout, that feeling where there seems to have been this shift in culture where it has become a job instead of a purpose. It has become a job instead of a passion. And I believe that's kind of what you're alluding to, is when people don't feel fulfilled in the work they do, it seems to be an easy shift for that to transition over to it's just a job, it's just a paycheck. Because I think in all of this discussion, the one thing that gets lost is the fact that it's not physicians and patients, it's people.
That's right.
Some people happen to be physicians. Most people end up being patients at some point in their life. Mm-hmm. And so I do think, like you say, that's the profound part of this, is where Compassionomics talks about the healthcare side of things. Wonder Drug very much talks about how each of us needs to pay attention to these stats. And I bring another one up, as I'm sorry I rattle so much at you, but 35% of Americans, if I got that set right, 35% of Americans say that they experience chronic loneliness. And that to me is a crisis of epic proportions. When the three of us, you met earlier, Josh, Jordan, and myself, were getting ready for this conversation with you, and we read that stat to each other and said that means that one of us, statistically speaking, is experiencing chronic loneliness. So how is a study like that conducted, and what does this say about where we're at as a society in a whole?
Well, we covered a lot of ground there. First, I want to say,
I know I did.
to your wife, who's a nurse, this is studied rigorously, like every year. What is the profession that Americans hold in the highest esteem, the highest honor? And year after year after year, it's nurses, and rightfully so. So I say all the time, I might treat patients, but it's really the nurses in my ICU who take care of patients, and they have a very unique and special set of skills to do that. And I've learned more from watching nurses and how to take care of patients than from all the textbooks and journal articles I've read over my career. So we're very thankful for her and for all of her work. The Surgeon General in the U.S. has actually written a book about this, about the loneliness epidemic and our lack of connection. And there are data on this. An NIH-sponsored study from just a few years ago shows that our self-care techniques, so we've all heard, what self-care is, taking care of oneself. These things are becoming more and more isolating. So in decades past, we used to find solace in family and friends. And what the research shows is that people's self-care practices are becoming more and more isolating. Go for a nature walk by yourself. Put on your headphones and block out the world and listen to your meditation app. Or do yoga and be on your island in the middle of the yoga studio, and things that are going more deeper inward rather than focusing outward. So more on yourself rather than connecting with other people. And what we did in Wonder Drug, which is our second work, we go through all that evidence and how we got there, where it's a culture of it's all about meism. And then we review all the scientific evidence that actually serving others and being other focused is the best medicine for yourself. And we back that up with over 250 original science research papers to make that case. And so it is connecting with others that can have measurable beneficial effects, not only on your mental health, but your physical health as well as your happiness, well-being, even your professional success. So what the data support is that, and this is, I can say broadly, if it's one thing that Dr. Maz and I have found over the last 5 years of doing this work, it is this: the key to resilience is relationships. The key to resilience is relationships. And that rings true both in healthcare, but broadly across all walks of life.
Well, the human connection in so many ways, we were talking about this recently, of this notion of filling your cup. Like you said, taking time to take care of yourself, but the fact that a connection with another human can fill your cup. And with a lack of that, it's difficult to pour from an empty cup, to give all of yourself when you're not giving to yourself. So I think that's something that people also don't realize, is that this notion of taking care of others, being in service of others, has such a benefit for yourself that again, there's really no excuse not to do it. So what I wonder is you had talked in there about the act of giving to others and the benefit of what gives it back. This is whether it's a charitable donation or it's giving your time to something that matters to you, and the difference that can make between what you do in your personal life, the success you find in your own life. Can you talk to me about that a little bit and expand on that? That when we do give to others, it doesn't just make us feel good, but we actually see a physical impact in our own life.
Sure, I can tell you about an experiment. I call it my N of 1 experiment. So unlike all the studies that we cover in our books, this is one that was unpublished, and it was one that I found out myself. So this is where the science meets the personal for me. So after, at that time, close to 20 years of working in the ICU, we were starting our work on Compassionomics, but I was in a bad place. I had every symptom of burnout myself. And the three cornerstones, or the three legs of the stool for burnout syndrome, are depersonalization, which we already said is an inability or difficulty making personal connections. Number 2 is emotional exhaustion. And then the third one is the feeling like you're not really making a difference. And I was batting 3 for 3 there. But that was when we were diving into all the data, and I saw this signal in the data that was very different from what I had been taught in medical school. So what I was taught in med school, literally, is don't care too much, because too much caring burns you out. And I believed that dogma for 25 years. I never thought to question it until I was in the throes of burnout myself. And I looked at this is how much of a research nerd I am. I actually looked it up on PubMed, which is like the Google for medical science. And the conventional thinking had been, get away more, take more vacations, go on nature hikes, do yoga, just as if, to me, that was escapism. To me, that says, well, if I just get away from my patients as much as possible, then everything will be great. But how is that even sustainable? So I wasn't believing it. I thought that something fundamentally had to change at the point of care, not an escape. And that is when I started to go through the scientific evidence and going through PubMed. And imagine my surprise when I found that compared to what I was taught in medical school 25 years earlier, that was conjecture, stories, anecdotes. But now there was bona fide peer-reviewed research. And what it showed, in fact, 80% of the published data showed an association between compassion and burnout. But it's inverse. So if what I was taught in medical school was true, too much caring, too much compassion burns you out. It's high compassion, high burnout, low compassion, low burnout. But what the research shows is inverse: high compassion, low burnout, low compassion, high burnout. Why? Relationships. So if you get the relationship that flows from more connection, then you get the good part of what it means to take care of patients. If you don't, then all you have is a really stressful job, to your wife's point. And so that's when I decided I was going to do my N of 1 experiment. I was going to care more, not less, lean in rather than detach and pull back and escape. And not just with patients and families in the ICU, but with the nurses that I'd worked with for more than 15 years at that point, with my trainees, with my colleagues, but even at home. And I got the deeper relationships that flowed from that. And that was when the fog of burnout began to lift for me. It changed everything. And it's evidence-based. So it may be my N of 1 experiment, but 80% of the published literature shows a inverse signal between more caring, more compassion, and lower burnout. And so if we're going to be evidence-based about it, and by the way, I need to say this loud and clear, just to make sure I don't forget to say this. You don't have to be a frontline healthcare worker to feel burned out. That's just the population in which most of the research has been done. But burnout is everywhere. I mean, anybody can be burned out, especially after years of a pandemic. And so what the research shows is that if you feel like you're burned out, you're in that place, test the compassion hypothesis for yourself. Lean in rather than detaching and pull back, and make more connections, not fewer connections, rather than going deeper withinward. Turn your attention life outward. Research from the University of Toronto shows that in everyday life, regular people have nine empathy opportunities every day. And when I think about that, it makes me wonder, like, how many did I already miss today? So look for those opportunities. Look for those opportunities to give people your 40 seconds of compassion, and see how it changes your experience, because it changed everything for me.
9 different opportunities in a day is a little bit shocking, because I wouldn't think that. I was retracing my own day in my head, but I guess when I examine it, the evidence is there. Mm-hmm. My question for you is, when you made this change, when you realized the inverse was actually the reality, was it a difficult transition for you to suddenly, after 25 years of thinking one way because it's what you were taught, to now lean into the empathy, to lead with that? Was it a tough thing to do, or did it come naturally just as a human?
When you're in the throes of burnout, you really don't have many other options. You feel like your back's up against the wall. So what was I going to do, right? The other thing is that I'm a research nerd, and there was tons of evidence. So, that sort of speaks to me. But you do have to be very intentional about it. It can't just be casual. Like, you have to be intentional about it. But I had to be intentional about it, or I was going to have to find something else to do with my life. Anyway, you have to be very intentional about it.
Well, and to dig a little deeper on that, do you remember a day personally when you woke up and you realized that this was working? That you said the fog lifted. Do you remember that feeling that day when you were like, not only am I a data nerd, but actually I'm experiencing it, where you're like, I refound my purpose?
So one patient, actually a patient's family member, comes to mind. So I was taking care of a 55-year-old man who had septic shock. So that's when a patient has overwhelming infection. It's a very lethal condition. And I could tell just by my 20 plus years of experience at that time that he wasn't going to make it through the night. And I had to give that message to his sister, who was just a couple years younger than he was. And it was a hard talk. It always is, as you can imagine. But at the end of that talk, and I thought we were done, she asked me a question that I had never been asked before in the ICU in 20 years. At the end of what I thought was the end of the talk, she said, "You don't remember me, do you?" I said, she said, "It's okay. I wouldn't expect you to remember me. You guys are so busy in here. You take care of so many patients. But I need you to know something." And she took her hand and she pointed it to the ICU bed directly across the hall from where her brother now laid. And she said, 7 years ago, my mom was in that bed right over there. And she was dying, and there was nothing that could be done to save her. And you were her doctor, and you had to tell me that. So you and I, we've had this talk before. And it took my breath away. But what she said next, I'll never forget as long as I live. She says, "Here's what I need you to know. Those nurses, they held me in those days when mom was dying. They let me know I wasn't going to go through this alone, and I didn't because of them. And so what I want you to know is every time I think about losing my mom, and I think about it every day because we were so close, and it hurts so much. But every time I think about losing my mom, I think about those nurses, and it makes me feel better even now." 7 years later. So she didn't just remember it. It was actually therapeutic for her. 7 years later. See, there's something about healthcare experiences that stay with people, reverberates, goes on in an echo chamber. What do you want to be remembered for? And so it wasn't just that, and by the way, ICU nurses are like Olympic champions in compassion. They probably went home that night and didn't think much of it because this is just who we are. It's what we do. Maybe a few weeks later, they wouldn't even remember what happened. But she not only remembered it, it was therapeutic for her 7 years later. So what I teach to my students here at Cooper Medical School, all my resident physicians, fellows, I teach this principle that this is going to go on and on and on. What do you want to be remembered for? And when you think of it that way, you look at every opportunity you have in a different way. It feels different to you. And that's what I think about when I'm having a tough day.
Well, and I just think, what if they were prescribed that notion of careless? What kind of a negative impact that could have had in that situation? The opportunity, like you said earlier, the opportunities missed for compassion can be just as impactful as those opportunities seized.
Totally.
So in looking at that, and my assumption of all of this is that this is not a very large chapter in the book of medical school, the idea of leading with compassion. So I wonder from you 2 questions. What concerns you the most about the future? And on the flip side, what gives you hope that we can turn this around and move in the right direction?
Wow. What concerns me is that we seem to have valued things that cause us to go deeper withinward. And I'm not just talking about healthcare right now, but whether it's, your face in the phone, so many efficiencies that can take the human connection out of things. And those are the things that make things actually meaningful. I worry that we are on a trajectory of less connection rather than more connection. And, you stated the data earlier about chronic loneliness. I worry that could get worse. If we follow the data, we see a different signal. I mean, serving others is in fact the best medicine for yourself. And there are over 250 original science research papers. So that concerns me. In terms of hope, I tend to be, I try to be a hopeful person because I think it matters. Cynicism is not evidence-based, by the way. We could do an entire podcast episode on that, on the data behind that. But just take my word for it. Cynicism is not evidence-based. What gives me hope in healthcare specifically are the young people that are young and impressionable. And, I think we can get rid of and dispel the hidden curriculum, so to speak, that, don't care too much because too much caring burns you out. I think we can replace that with what is actually evidence-based, which is that the key to resilience is relationships. And if you follow the science, it will lead you to compassion. If you follow the science, it will lead you to serve. And if you follow the science, it will lead you to years and years of whether it's a career in healthcare or just spending a lifetime making connections and serving other people. It will lead you to joy that is beyond anything you could possibly imagine. And that's not a wish. That's not a platitude or a bumper sticker. It's actually supported by a whole lot of rigorous scientific evidence.
Steve, I have to say, I when I say thank you for being on this podcast, it is very sincere. What I was able to learn and glean from the research that you and Dr. Maz were able to do, and having this conversation, it impacts me very profoundly. It impacts me and my entire team with what we do. And this is a conversation that I think if we could start a positive epidemic, it would be to have more of this conversation and as often as possible, because I think it's the only way that true change is going to happen is to get this word out to as many people as possible. So for that, I say sincerely, I can't thank you enough for being here and what was a truly illuminating conversation.
Jason, the pleasure's all mine. Thank you so much for the invitation, and keep up the good work.
I hope our conversation provided value to even one of you out there listening. And if you've made it this far, I want to thank you for being curious. If you haven't already, hit that like and subscribe button to join our weekly conversations and become a part of our community.